今天我们来到西方医学发源地希腊首都雅典，采访 EABIP 主席、雅典大学 Sotiria 医院第一呼吸内科介入性肺病科主任 Grigoris Stratakos 教授。感谢专注内窥镜56年的 Endoscopy SA 公司的大力支持。
Dear Professor Stratakos, I know you are very busy. Thank you very much for coming here and accepting our interview.
Thank you for inviting me. It's an honoring invitation and the pleasure is mine.
You have more than 20 years of experience in your professional field. Could you please share with us your journey and experience along the way?
Well, it's true that it took a lot of years because I started with the Pulmonary Medicine Fellowship back in the 90s, and then I had to do the intensive care unit training also for 2 more years. And then I realized that I had a tendency, and my favorite was the interventional procedures. But at that time in Greece, there was no expert in interventional procedures to train me, so I had to travel in Europe. I was lucky enough to have a very important mentor, Professor Mark Noppen in Belgium. So I was trained with him for 1 year and a half, and then I was lucky enough to visit most of the expert centers of excellence in Europe, Heidelberg, Marseille in France, Ancona in Italy, and met very important people in this field. So when I came back to Greece, 2004, 2005, I had to build from scratch an IP unit, and it was not easy. I had to introduce new techniques, and other colleagues did not know them, so it took a lot of work. I think the nicest and also the most difficult thing was to build a team of collaborators, of assistants and colleagues and nurses, which would be stable and what it is difficult to do. But hopefully we did that, and nowadays we're very active also in training other people, and we have been recognized now as one of the very few centers in Europe that provide high-level training in interventional pulmonology and especially in endobronchial ultrasound.
Which new bronchoscopy procedure do you think is the most important or related in lung case management?
Lung cancer is a major challenge nowadays. It's very common, both in males and females. And with the lung cancer screening test we're doing with low-dose CT, we discover a big number of little nodules in the lungs, in the periphery of the lungs. And we do not have a very easy means to access these lesions with the bronchoscopes or the CT FNA needles. So there is a very important research done on the modules of access to the periphery. So we need very thin bronchoscopes, electromagnetic navigation or fluoroscopy to guide us to the periphery with radial ultrasound probes that can be advanced in the periphery of the lungs. I think this is one of the major challenges we are going to face, and it's very important because not only diagnosis but also local treatment can be delivered through these technologies.
In addition to the clinical work of using bronchoscopy for diagnosis and treatment, you have also carried out a wide range of research and education projects. Could you please share with us the latest progress and the future plan?
We started with participating in multi-center studies for lung emphysema treatment with bronchoscopic lung volume reduction with valves and other modules, and that was successful. And we're very active in treating central airway obstruction, either due to malignant disease or benign disease, with rigid and flexible modalities. So we were the first to prove that we could increase survival of lung cancer patients if we intervene in the central airways. At that time, before our publications and research, the patients with lung cancer who had involvement of the central airways were thought as end stage, and nobody would treat them. But we proved that if we canalize the central airways, these patients could receive other treatments and then survive for many years. And that was a major success, I would say, for lung cancer management, because we understood that interventional pulmonology management of the central airways is a very important part of the oncological treatment in lung cancer, which is very often. And I will tell you one last example. During the COVID pandemic of the last years, a lot of people, of course, were intubated in the ICUs, and there was a parallel epidemic of tracheal stenosis after intubation. And this also should be treated and can be treated. And we were one of the first in the world who showed that we should have an algorithm for treating post-intubation tracheal stenosis in post-COVID patients, because they have some differences. They're not like other post-intubation stenosis, it's more different. So we have to treat that.
You established a new modern interventional pulmonology unit at Sotiria Hospital. How has it progressed since its inception?
Sotiria was my second unit. My first unit was in another hospital, Evangelismos. When I took an academic position in the university, I had to move to this hospital in Sotiria as a professor of pulmonology. It was difficult because that coincided with a financial crisis in Greece. So that was a major challenge, to develop a new unit with new equipment, with modern instruments and so on, in a bankrupt state. It's not easy. So first of all, we designed well the unit. I wanted to dream high, as we say, to set difficult goals. And even if not all of them were attainable at that moment, but I was trying to anticipate the future needs and how this would be served. So we made a good plan of development. And then we started to exploit every possible solution for funding, from public funding, with a lot of advocacy in the media, trying to explain what we want to do and how we want it to work. And then we had the first basic instrumentation and equipment. And then we tried to establish some international training courses, so bring foreign people here to get training. And of course, that secured also funding for the development of our units. So very soon we were able to pay salaries for our assistants, to buy new equipment, to maintain older equipment and so on. And we also asked for donations. I had a program of explaining the needs of this unit to people who had the possibility to provide funding. And this is, for example, the way we purchased a big simulator for bronchoscopy, which is very important. We have a very modern and very efficient bronchoscopy simulator machine. It's one of the very few existing in the world. And so we became a center of excellence in training on simulation basis without having to use patients as training way for the new doctors. So we tried to be high and modern and work hard. And for that we had also to work a lot and accept very challenging cases from all over the country, 24 hours a day, 7 days a week. So there was a team hard working, but it was rewarded by these results.
Thank you very much for your long-time effort and great contribution to medical industry. In your opinion, what defines a good doctor?
Well, first of all, because I like history of medicine, you know, this is my hobby, reading history of medicine. I have realized that medical knowledge changes very, very soon, of course, very often. So it should not be medical knowledge, because medical knowledge, okay, is changing. So what defines a good doctor should be something else, should be the care for the patient. Should be the love for the patients. You know, good doctors there were always, even when they did not know anything of our knowledge today. It's incredible to think that in the 50s, not so many years ago, there were no antibiotics, there were no cortisone, there was no bronchodilators, there was no insulin, and still there were good doctors treating patients and caring for them and making them well. And I think the difference is that how much you're interested for your patient and how much you want to be the role of therapist, the role of the one who will take the pain out of an individual and try to help him.
Yes, you are a good doctor.
I don't know. Thank you for saying.
What challenging case have you encountered in bronchial treatment? How did you solve it?
Well, I can remember of many, but one of the most interesting was the complications of thoracic surgery. And when you're in a big hospital and you want to be established as an interventional pulmonologist, you have to solve problems of the surgeons very often. And so we encountered a big number of bronchopleural fistulas, bronchopleural communications after surgeries, which is a difficult problem to solve and a very debilitating one. So patients are very sick if there is communication between the bronchi and the pleural space. So we invented and developed a method of closing this fistula with silver nitrate application. So we used catheters, bronchoscopic catheters of silver nitrate. We made them ourselves, and we produced a local inflammation burn on the fistula orifice, which then was closed. And we were the first to publish this. And well, it's a rare problem, but in a big hospital you can see several cases a year. So we did that.
As the current president of EABIP, can you share with us the current situation and the advantage of bronchoscopy in medical practice?
Yeah. As I told you, interventional bronchoscopy in pulmonology is now led by the evolutions of the new treatments in lung cancer. So first big challenge is what I just mentioned about the peripheral approach in the lung, but also central airway management with endoprosthesis, with stents, because we have new research data on producing active stents for the airways, not only mechanically acting, but also chemically acting, drug-eluting or radioactive stents, or self-dissolving stents. And this is a whole new field of a challenge. And also, there are a lot of treatments for obstructive lung disease, COPD, bronchitis, emphysema, or asthma, which can be delivered by the bronchoscopes. And of course, we are also involved in the diagnosis and treatment of diffuse lung disease, interstitial lung disease, and we can take cryobiopsies from the periphery so we can avoid major surgeries. Another thing that we're trying in the EABIP is to homogenize education and training of pulmonologists around Europe. And for that, we collaborate with the World Association for Bronchoscopy and Interventional Pulmonology, trying to deliver training in a standardized level of evidence-based medicine, so to ensure that all over the world, patients would have access to correct medical procedures. And thus we have developed a program of training, and we use simulators to train our doctors and assessment tools. So we have to assess their skills and accredit them. It's a long work.
In your opinion, what specific area should the medical device industry focus on in the future? What innovation and breakthroughs are needed?
There is a lot of research on airway stents, as I told you, and I know that there are several companies working on modern third or fourth generation airway stents, which first should be very friendly to the mucosa and to the airways and be active, so delivering treatments, and then dissolve when they will not need it anymore. So that's one. Airway stents is a huge field of industry research and development. As far as bronchoscopic equipment goes, I think that there are new ideas on hybrid bronchoscopes which can have flexible and rigid properties alike, and which could also include some ventilatory equipment, jet ventilation, for example. So if we have these simplified scopes that could deliver rigid treatment and flexible treatment together and have ventilation secured, then that would make these interventional pulmonology modalities available to a larger group of doctors. And the third thing, I think that industry can help us in our development of interventional pulmonology is artificial intelligence and simulators, which can help us train better our young doctors without having to train them on patients. So there are now simulators that can, in a very, very realistic way, simulate bronchoscopic environment or even thoracoscopic environment, but this has to get more evolution and involvement, and we're very keen to see more products on that.
How do you believe the introduction of disposable bronchoscopy has positively impacted patient diagnosis and treatment? What are your expectations for their future development?
Disposable bronchoscopes have helped doctors be flexible and versatile, so they can deliver treatments and diagnostic procedure wherever this is needed, from the emergency department to the ICU to the operating theater or even by the bedside. We have found that very useful in emergency situations in the clinic, in the hospital. For example, last month I was called that for a massive hemoptysis in a patient who was hospitalized in the ward, and we had to use disposable scope to go quickly and try to save the patient by aspirating blood and securing electrosurgical hemostasis. So this would not be done if I had to move the whole tower with all the equipment and so on. So versatility and flexibility is one major advantage. Also, patients have been saved from contamination of infections. So we can save some infectious disease contamination. And also, we can reduce the cost of reprocessing materials and sterilizing equipment. So there are several advantages. I think that if the evolution of these disposable scopes goes versus the development of hybrid forms of scopes with some parts reusable and some parts non-reusable, single use, which could work together, that may reduce both the environmental footprint as well as the cost, which are the major drawbacks for their larger, broader use. I think this is something you should consider.
Okay, thank you.
Thank you.
Thank you very much for the interview.
It was a pleasure. Thank you very much for honoring invitation.
开拓者永不止步，从一始终不断探索，以己所学，尽己之力，解肺之急，生命至上。华新医疗期待与教授并肩同行，为肺癌患者带来新希望，让肺自由呼吸。